So as I stated earlier, when we do a urinalysis, the exploration or the exam doesn't really end there. That's just the first step. So let's say our patient comes in, they have dysuria, so the painful urination, they have polyuria, they're having to go all the time. Maybe they're febrile, meaning there's a bit of a fever, so now we're concerned about the kidneys. So we do that urinalysis, we see there's evidence of urinary tract infection, red blood cells, white blood cells, we see elevated nitrates. So if we see all three of those, that generally means that there is a urinary tract infection going on, but we don't stop there. If the doctor feels it's bad enough, they might prescribe an antibiotic exactly in that setting for the patient to start right away. Behind the scenes, we're going to take that urine specimen, we're going to draw it up into a tube and send it off to the lab. And this becomes standard of practice in the last several years to do a CNS or a culture and sensitivity on all urinary tract or suspected urinary tract infections to make sure the right antibiotics are being applied for effective treatment. So we send a specimen off to the lab. The lab will do their own urinalysis via dipstick, and then they'll do a culture and sensitivity, which you see depicted here. So they'll take a sample of the urine, and what they will do is they'll create a culture out of it to find out what kind of organism it is. So basically they take some of the solutes, if they can get them, and sometimes they use just the urine itself, and they put it in a petri dish, and you see that depicted here. So there's a certain type of gel at the bottom of that dish that allows that bacteria to grow. And they want to find out what kind of bacteria is causing this illness or infection. So they put this in the petri dish, this goes into an incubator, and it cooks for a certain amount of time. And it's interesting, when I worked as a phlebotomist, I got to see this process a few times. And when they take that petri dish out, when the bacteria actually had a chance to grow, sometimes it has almost a crystalline look to it. There'll be these little structures and these little dots all the way around here where they've put different types of urine specimens. And usually they're all in one patient in the dish. So that's the culture. So now we have a culture. Now we've got this pathogen, we've isolated it, now it's grown, so now we have a specimen. Then they do a sensitivity. So this is different types of antibiotics that are applied to all these different specimens to see which ones will affect it. So what you see depicted in this picture here are these little round objects are antibiotic discs, and they're being placed at different parts of this urine specimen to see how they're going to react. Each antibiotic disc represents a different type of antibiotic. The most effective one that we use for urinary tract is macrobid. But there are other forms that we use as well. Cipro is another one that's used these are commercial names for antibiotics. So they'll use a variety of antibiotics. And by the way, they also do this with wound cultures too. If they need to know how to treat that particular bacteria, they isolate it by doing this culture. Then the sensitivity comes with these antibiotic discs as they're placed. And then you look and see if they have any bacterial growth. And within that bacterial growth, you're looking for zones of inhibition. So, if you look in the lower left corner of the petri dish, you see resistant to antibiotics. So that antibiotic placed there, and you can see that pathogen that it's sitting in, that bacteria that's been grown from that urine specimen, that antibiotic has no effect on it. So we do not want to treat with that antibiotic. If we go over to the other side, on the right side, you see zone of inhibition, and it points to that big dark circle around those, and you see on several have dark circles of varying sizes. Those are more effective antibiotics. Those with the largest ring around them will be the most effective for that type of bacteria. So they may have given you Cipro and sent you home with it and said, we'll give you a call in a couple of days and check on your symptoms. And maybe you've had this experience. So you start on the Cipro, suddenly the medical assistant calls and says, okay, the doctor got your culture and sensitivity back. We're switching you to macrobid. We've already sent the prescription in. Stop taking the Cipro, start taking the macrobid by instruction today. And that means that in the office, we've got the specimen. The doctor said, well, we're going to start on a general antibiotic. Then we'll get more specific. To get the culture and sensitivity, oh, well, it's not sensitive to Cipro, but look, it's sensitive to macrobid. So we changed the antibiotic. If you've ever had that experience, that's what was going on. For those of you who are going to work as medical assistants and nurses, you will see this process happen recurrently. It's just the way we treat bacterial infections. As I said, we're talking about urine specimens here, but this can easily be done for a wound culture or other types of bacterial infections. Doesn't work with viruses because viruses do not respond to antibiotics. Okay, so here's a condition, edema, excessive fluid in the body tissues that causes swelling. So edema can mean a couple of things. Could mean congestive heart failure, could mean kidney failure. If the kidneys are unable to filter the excess water out of your body, that water has to go somewhere, so it distributes itself out through the tissues in the body. Gravity, of course, will pull it down. What happens is you see exactly this. You'll see swelling in the bilateral ankles, and they will sometimes get very large. So you may see patients who are, are diabetics, or you suspect they might be diabetic, but maybe you haven't seen their chart, and you'll see this abnormal swelling in the ankles, and sometimes it'll actually hang over the side of the shoes. That's edema. That's excess water that the body can't get rid of, has to go somewhere, and if the kidneys are failing, or if the heart doesn't have enough strength to push the blood through the kidneys at the pressure that it's needed, as in congestive heart failure, edema is going to result. That water is going to start filling the ankles, and it's going to move its way up the leg. We don't ever want it to get past the ankles because it's very severe if it does. How do we get rid of this? We use something called the diuretic. Now, your brain produces something called ADH, antidiuretic hormone. It tells the body when to hang on to urine and water and when to let go of it. That's how it comes out of the hypothalamus, and it goes to the endocrine system, and it's part of homeostasis. And let's say you had a salty meal, and the hypothalamus goes, oh, we need to retain water. So it's going to say, okay, don't filter this water out, retain the water. And let's say you had that salty meal, and forget the or. Let's say you had the salty meal. Your body's saying, hang on to the water because the salt is dehydrating me. But then you drink a bunch of water and it kind of balances out. Now maybe you have too much. The brain then pulls back the antidiuretic hormone and you'll be able to urinate. When the system's failing, as in kidney failure, and now that fluid is collecting in the ankles, as in edema, as we saw in the previous slide, we have to get the fluid off the body somehow. So we use a diuretic, which is a prescription form of the hormone I just described to you that's normally released by the brain. This is Lasix, and Lasix is very common. Furosemide is the medication that it represents. So Lasix is the product name, furosemide is the actual medication. This is a drug used to control edema and to increase the excretion of urine. So this will replace the ADH hormone, its presence or its absence. This would be an artificial way of stimulating and repressing the antidiuretic hormone so that the patient can urinate. And so when you hear diuretic, you often hear patients refer to it as the water pill. This is what they're talking about. They either have kidney disease, heart disease, or God forbid, both going on at the same time. Their body's not getting rid of the excess fluids, so they're using this medication to get rid of it. There are other uses as well. So just because someone's using a diuretic doesn't mean it's heart failure or kidney failure. But it's a very strong chance that that's why it's being used. We also have some terminology that's specific to medications. I'm just going to run this down for you. This will constitute your abbreviations for this week. So we have RX means prescription, recipe, or to take. If the doctor wants you to take it as desired, let's say erectile dysfunction medications, you could use those ad lib, as desired. So before relations, you would take them, and that's what the doctor would write to the pharmacist. Now the pharmacist is going to write on the label there, the directions. They're going to say take one as desired, but the doctor's going to order take 1 tab ad lib, or they could say PRN is needed. That might be an anxiety medication. So the doctor will write PRN on the prescription. The pharmacist will interpret that as needed. So the prescription then would read take 1 or 2 or 3 tablets as needed. If you're supposed to take them twice a day, the doctor will call that BID. 3 times a day is TID. 4 times a day is QID. AC means before meals, likely a diabetic medication. PC means after meals, which could be a GERD medication or a diabetic medication. And HS at bedtime. There's a whole lexicon of abbreviations we use when it comes to medication terminology. If we were in the classroom, I'd give you a lot more information and show you how it works. But being that we're doing it a video lecture as this one, I'll just give you the essentials. So for those of you working in nursing, medical assisting, these will be very important terms to know because doctors will be using those terms on the left. They're going to expect you to understand the terms or the definitions on the right and what they mean. Enuresis. This is classic bedwetting. Nocturnal enuresis is what we officially call it, but enuresis, if you use that, people will know. It's involuntary discharge of urine at night, a condition usually affecting children. So parents out there, if you've ever had to go through the whole learning to use the potty thing, this is one of the challenges that we go through. So this is involuntary discharge of urine at night, but it's because bladder control has not yet been learned in most cases. Now, there's another form of this that happens in adults, usually in older adults, and it's called urinary incontinence. And this is a little bit different because it's happening much later in life. This is a loss of bladder control. It primarily affects adults and becomes more common with aging. So the muscle tone deteriorates as we get older, collagen breaks down, and that's kind of the structure that keeps us all, keeps everything functioning in terms of muscle and skin and all of that. So as those sphincter muscles begin to fail, urinary incontinence is a possibility. I had mentioned this earlier in terms of catheterization. Some folks with urinary incontinence will choose to go the route of catheterization as long as the urologist is okay with it, which means they insert a catheter to themselves. They have a bag usually strapped to the leg, and that will drain the urine, and that prevents them from having to wear what used to be called adult diapers, and now we just call them briefs. So the terminology has changed on those. So urinary incontinence is something that's going to happen likely to a degree as you get older, but it doesn't happen to everyone. I would say, just empirically speaking, from my personal experience, probably 80% of patients over the age of, say, 75 or so had some form of urinary incontinence. But once again, that's a small slice of the population I've been exposed to. That's a few thousand patients. The real stats you'd have to look up. Okay, intra means within. Intravenous means within. And this is all leading, of course, to a very important concept I want to get across to you. And I'm going to end the lecture right here and start the next segment. And we have just a few more slides to go, and I'll be able to fit everything there. So I'm going to end this one a little bit earlier. And we're going to end with intravenous, so within a vein. So this is typically what we do when we start an IV. It's not what you do. Well, it is what you do when you're a phlebotomist. You are going into a vein. It is intravenous, but for different purposes. So just remember, intra means within, and venous is technically pertaining to within a vein. Pause it there. I'll be back with you in just a moment.